Welcome back to our weekly neurology deep dive.
Always great to be back.
As always, before we get started, just a reminder that this podcast is purely for educational purposes.
Absolutely. No commercial interests here.
We're just trying to summarize some really interesting research, but this doesn't replace reading the full paper.
Definitely encourage everyone to check out the full publication for all the details.
Okay, so let's dive into our topic today. We're looking at the long-term safety and efficacy of weekly Rozanolixizumab.
That's right, focusing on patients with generalized myasthenia gravis.
And the data we'll be exploring comes from the MG0004 study.
Interesting study. This one follows up on the Phase 3 MyCaring trial, which showed some promising short-term benefits of rozanolixizumab.
So the idea here was to see what happens with longer-term treatment.
Exactly. More of a real-world scenario, right?
Precisely. Now, can you tell us a bit more about who was included in the MG0004 study?
Well, it enrolled patients who had already participated in that MyCaring trial.
Oh, so they were already familiar with the treatment.
Yes, and importantly, they all had acetylcholine receptor or muscle-specific tyrosine kinase autoantibody-positive generalized MG.
I see. So a very specific patient population.
Makes sense. You want to keep things consistent when you're looking at long-term effects.
Right. So how did the MG0004 study actually work?
Okay, so patients were randomly assigned to one of two groups.
Half and half.
Yeah, 1-to-1 they call it.
Okay.
One group received 7 millikilograms of subcutaneous rozanolixizumab every week.
And the other?
The other got a higher dose, 10 millijoule-kilogram, also weekly.
And this went on for up to 52 infusions.
That was the goal, yes. But there's a little twist to it. After at least 6 infusions, they had the option to switch to another study.
MG0007.
That's the one which looked at cyclic rozanolixizumab administration.
So some patients didn't complete the full 52 weeks.
Right, which makes sense in a real-world setting. Treatment plans evolve.
Absolutely. So what exactly were they measuring in this study?
Primarily, they were looking for treatment-emergent adverse events, or TEAs.
Any side effects, basically.
Pretty much. And especially TEAs that led to patients stopping the treatment.
Okay, makes sense. Safety first.
They also looked at secondary endpoints.
Such as?
Things like MG-specific outcomes.
Measuring how well the treatment actually worked.
Exactly. Things like MG activities of daily living, or MG-ADL scores, MG composite scores, and quantitative MG scores.
And did they track whether patients needed rescue therapy?
Oh, absolutely. That's a crucial part of understanding how well a treatment is working.
So out of those 70 patients who started, did everyone stick with it?
Well, because of that option to switch to MG0007, the average treatment time was about 23 weeks in both groups.
Still a decent chunk of time to observe the effects.
Definitely gives us some valuable insights into the longer-term impact of rozanolixizumab.
Okay, so let's get into the nitty-gritty, starting with safety.
All right, so when it came to those treatment-emergent adverse events, 85.7% of patients experienced at least one.
That sounds like a lot.
It is a high percentage, but the good news is most of them were mild to moderate.
That's reassuring. What were the most common ones?
Headache was the most frequent, popping up in 35.7% of patients.
Pretty typical for any kind of medication, really.
Then we had diarrhea, affecting 18.6%, and 15.7% had a decrease in their blood immunoglobulin G levels.
IgG, that's the antibody, right?
Exactly.
Okay, so nothing too out of the ordinary so far. What about serious adverse events?
Okay, so serious TEAs were reported in 12.9% of patients.
Still a considerable number.
Yeah, but the investigators didn't think any of these were actually caused by the rozanolixizumab.
Really? None at all.
That's what they concluded. Now, the specific events varied between the groups.
Let's break those down then.
In the 7 millijoule group, there were 3 cases of MG worsening and 1 case each of some other issues.
Like what?
An abnormal kidney biopsy, congestive heart failure, muscular weakness, and even a retinal detachment.
Wow, that's a pretty diverse range. And what about the 10 millijoule group?
They had 1 case of pericarditis and 1 case of MG worsening.
Interesting. So both groups saw some instances of their MG getting worse.
And here's something to note. Some of the MG worsening and muscular weakness actually happened after the patients had stopped taking rozanolixizumab.
During the observation period.
Exactly. So it's not entirely clear if those were directly related to the treatment.
That makes it tricky to interpret.
It does add another layer of complexity.
Definitely. Now, did any of these adverse events lead to patients dropping out of the study?
Yes. Unfortunately, 5.7% of patients discontinued treatment due to TEAs.
Was this spread across both groups?
Actually, all of these discontinuations were in the 7 millijoule group.
Really? Any particular reason?
The reasons cited were MG worsening and congestive heart failure.
So potentially related to those serious adverse events we discussed earlier.
Possibly. But again, it's hard to say for sure without more information.
Right. We always have to keep those limitations in mind.
Absolutely. Now, moving on to something neurologists are always concerned about. Infections.
Always a risk with treatments that affect the immune system.
The overall infection rate in this study was 28.6%.
That's higher than the general population.
It is, but it's important to emphasize that there were no serious infections reported.
No opportunistic infections either.
None at all. No severe infections, and no infections that caused anyone to stop treatment.
Okay, that's good news. So what about those hypersensitivity reactions?
17.1% of patients experienced those.
Hey, severe reactions.
Nope, none were serious.
And what about injection site reactions?
Those happened in 8.6% of patients. Again, nothing serious, and no one had to stop treatment because of them.
No anaphylactic reactions either.
None whatsoever.
Okay, so overall, it sounds like the safety profile is pretty decent, even with long-term use.
That's the takeaway so far.
Yeah.
Now, they did also look at other things like albumin, lipids, vital signs, ECG, all that good stuff. Nothing clinically significant to report there.
Any pregnancies during the study?
Just one, and it had a healthy outcome.
So far, so good. Now, let's move on to what everyone really wants to know. Did it work?
Let's dive into the efficacy data.
Starting with those MG-ADL scores, which you mentioned earlier.
Both dose groups actually showed clinically meaningful improvement in their MG-ADL scores.
So their symptoms were getting better.
They were. The 10 mg/kg group showed even greater improvement up to week 33.
Ah, so the higher dose seemed to be more effective.
It seems that way, at least up to that point.
Can you quantify those improvements?
Sure. The average reduction from baseline in the 7 mg/kg group was 3.1 points on the MG-ADL scale.
And for the 10 mg-ADL scale?
It was 4.1 points.
Okay, so noticeable difference there.
They also measured the reductions after 4 and 6 infusions.
Yeah.
After 4 infusions, the 7 mg/kg group had an average reduction of 2.7 points, and the 10 mg/kg group had a reduction of 3.2 points.
Getting better already. What about after 6 infusions?
The 7 mg/kg group stayed at 2.7 points, but the 10 mg/kg group improved further to 3.7 points.
Interesting. Did they see any difference between patients with AChR antibodies versus those with MuSK antibodies?
Nope, the trends were pretty similar for both subgroups.
Okay, what about those other scores, MGC and QMG?
Both of those followed similar trends. Improvements were seen, and again, the 10 mg/kg group generally did better.
What were the maximum reductions for those?
For MGC, the 7 mg group had a maximum reduction of 6.1 points, and the 10 mg group saw a reduction of 9.1 points.
Wow, that's a big difference for MGC and QMG.
For QMG, the maximum reductions were 5.4 and 6.2 for the 7 and 10 mg groups, respectively.
So consistent improvement across the different outcome measures.
It seems that way, but it's not just about those objective measures, right?
Right. Patient-reported outcomes are important, too. How did those look?
Well, they use something called the MG Symptoms PRO scales.
Yeah.
Patients reported improvements in several areas: muscle weakness, fatigability, physical fatigue, and bulbar muscle weakness.
So they were feeling the benefits in their everyday lives.
Exactly. And they also looked at some broader measures of disease impact.
Like what?
Things like the MG Impairment Index, or MGII, and the MG Quality of Life Questionnaire, MGQLO15R.
Those give a more holistic view of the patient experience.
Precisely. And again, they saw improvements on both of those measures.
What were the reductions for those?
For MGII, the maximum average reductions were 12.1 and 17.3 for the 7 and 10 mg groups, respectively.
And for MGQOL 15?
The maximum average reductions were 5.1 and 6.5 for the two groups.
So it sounds like the treatment was making a real difference in patients' lives.
That's what the data suggests.
Now, how often did patients need rescue therapy?
Actually, very few. Only 4 patients in the 7 mg/kg group needed rescue therapy during the entire study period.
That's encouraging. And what kind of rescue therapy did they receive?
It was all intravenous immunoglobulin or IVI'd.
Okay. And those 4 patients, were they all clustered towards the end of the study, or was it more spread out?
Interestingly, 2 of those patients actually received rescue therapy while they were still on Rozanolixizumab.
Oh. So even though the overall numbers were low, some patients still needed additional help.
It's important to remember that everyone responds differently to treatment.
Makes sense. Now let's delve into the pharmacodynamics and immunogenicity findings. What happened with IgG levels?
Okay, so they saw a pretty rapid decrease in total IgG levels, about 48% by week 2 in both groups.
So the treatment was definitely having an effect on the immune system.
And the maximum reduction was even more impressive, around 75–80%.
When did that happen?
That was reached around week 5, and it generally stayed at that level with continued weekly treatment.
And did they see similar trends for different IgG subclasses?
Yep, pretty much the same across the board.
Okay, what about those acetylcholine receptor antibodies?
Those also went down with a median reduction of about 60% by week 9 in both groups.
So the treatment was targeting those antibodies effectively.
It appears so. Now, one thing we haven't talked about yet is anti-drug antibodies.
ADAs. Those are the antibodies that can develop against the treatment itself, right?
That's right.
Did many patients develop those?
53.6% of patients actually developed treatment-emergent ADAs,
That's over half.
and 26.1% developed neutralizing ADAs, the kind that can actually block the treatment from working.
So was that a problem?
Surprisingly, no. Generally, the presence of ADAs didn't seem to have a meaningful effect on how well the treatment worked.
Really? Even the neutralizing ones?
They didn't see any clear trends there, no effect on efficacy outcomes, and no apparent impact on the safety profile either.
That's interesting. So even though the immune system was reacting to the treatment, it didn't seem to interfere with its effectiveness.
That's the key takeaway here.
So what's the bottom line for neurologists?
Well, the MG00004 study suggests that chronic weekly Rozanolixizumab for up to 52 infusions was generally well tolerated.
No major safety concerns.
The most common side effects were mild to moderate, and serious adverse events were infrequent and not considered related to the treatment.
And it seemed to work pretty well.
It did. They saw clinically relevant improvements in MG-specific outcomes, and those improvements were sustained over time.
Plus, we saw those reductions in IgG and AChR antibody levels.
All a good sign.
So does this change how we think about using rozanolixizumab?
It definitely supports the idea that it can be used long-term, even for patients who need frequent treatment.
And even though it's currently approved for cyclical use, this study provides some valuable data on weekly administration.
Data that neurologists can use to make informed treatment decisions.
Absolutely. Now, were there any limitations to the study that we should keep in mind?
The biggest one is that MG00004 closed early because a lot of patients opted to roll over to that MG0007 study.
So we don't have as much long-term data as we might like.
Exactly. The data beyond week 33 is a bit limited.
Okay, fair enough. But for neurologists in their everyday practice, what are the key takeaways here?
I think the main message is that long-term weekly rozanolixizumab appears to be a safe and effective option for patients with GMG who need frequent or ongoing treatment.
Especially those who might not be doing so well with other approaches.
Exactly. And it's crucial to remember that we need to individualize treatment plans.
Of course, everyone is different, and what works for one patient might not work for another.
Absolutely.
So if our listeners want to learn more about this study, where should they go?
I'd strongly recommend reading the full publication. It has all the details on the methodology, the full results, and a author's discussion.
A lot more nuance than we could cover here.
Absolutely. And it's especially important to understand the context and the potential limitations of the study.
Great. So to wrap things up, I'd like to leave everyone with a thought to ponder.
Always enjoy those.
How might these findings on the long-term safety and efficacy of rozanolixizumab influence how we approach treatment for generalized myasthenia gravis in the future?
That's a great question. It'll be interesting to see how these data are incorporated into clinical practice.
Thanks for joining us for this deep dive, and we'll see you next time for another fascinating exploration of neurology research.
I'm looking forward to it.